So today we're going to talk about the femur and the hip bones. So when I'm talking about the hip, I'm talking about the joint that is made up by the femur and the hip bone, also known as the pelvic bone, also known as the innominate bone, also known as the ischium, the ilium, and the pubis. A lot of different names for this thing that I'm holding here in my hand. I'm going to make a completely separate video that's going to talk about this bone in more detail. But for now, the part of this bone that I want to focus our attention on is the part that receives the femoral head and directly participates in the hip joint, which is going to be this part right here. This is the acetabulum. So this is going to be the socket for the ball that is the femoral head to fit in like so. Okay, so first let's talk about the femur. So I talked about some features of the distal femur in the last video on the knee. So let's just recap on the major points there. The distal part of the femur is essentially composed of the lateral condyle and the medial condyle. The lateral medial condyle are very large. They sit right on top of the tibial plateau and they contribute to the formation of the knee joint. In between the two condyles is going to be the intercondylar fossa, and this is where the ACL and the PCL are going to be housed. You can also see that anterior to this is going to be this blue portion right here, which is painted blue, is going to be your patella, all right? This right here between the patella and the distal end of the femur is known as the patellofemoral joint. I will also make a completely separate video talking about the patellofemoral joint specifically in more detail if you're interested in that. Now, when we look at the rest of the femur, right, this is the long view of the femur that you can see here. We're going to have the long shaft that makes up the femur, and the shaft, we're going to look at the anterior side and the posterior side. When we're looking at the anterior shaft of the femur, we see that this has painted on it just one red attachment, okay? So this is going to be the attachment site for the vastus intermedius. The vastus intermedius is one of four muscles that arises from the anterior side of the femur, okay? This is the one that is directly attached to the shaft of the femur. You're also going to have the vastus medialis on this side, the vastus lateralis on this side, and the rectus femoris directly superficial to the vastus intermedius. And those four will make up your quadriceps muscles that will attach to the tibial tuberosity of the tibia that we saw previously, all right? So this is the shaft, anterior shaft of the femur. I want to really focus most of our attention on the posterior shaft of the femur, okay? And why? The posterior shaft of the femur, as you can see over here, has a lot of painted lines on it. And specifically, it's right on this part that's right on the midline of the shaft. So I can bring it up closer so you guys can see, all right? So this right here is known as the linea aspera, all right? The linea aspera of the femur, linea aspera translates to rough line. So this is the rough line of the femur. And this is going to serve as an attachment site for several muscles in the thigh, all right? So we're going to receive over here the vastus lateralis and medialis. Remember what I said before. Vastus lateralis and medialis are part of the quadriceps group, which lies on the anterior side of the thigh. So why are they attaching back here? Well, the muscle belly itself actually wraps around the femur, and lateralis attaches on the lateral side and medialis attaches on the medial side, and then the rest of the muscle belly will then go to join with the rest of the quadriceps anteriorly. But they do have attachments to this posterior aspect of the femur on the linea aspera. This is also going to serve as an attachment site for the short-headed biceps femoris, which is one of our hamstrings. It's also going to serve as an attachment site for the adductor magnus, which comes from the adductor compartment, and is also going to serve as an attachment site for our adductor longus, adductor brevis, and a portion of our pectineus, okay? So there's a lot of muscles in the thigh that are going to attach to this linea aspera back here, okay? Now, the next thing I want to bring our focus and our attention on is going to be the proximal aspect of the femur. So let's take a closer look for that. So now when we're looking at this proximal aspect of the femur, we're looking at the posterior side right now. And what I want to bring our attention to, let's talk about the femoral head first. So the femoral head right here, very round and spherical to fit into the acetabulum. One thing I want to point out is right here. So you see this little hole over here? This is manufactured. This is for the skeletal model. Ignore that. What I want to bring your attention to is that depression that you see right there, okay? This is known as the fovea of the femoral head, all right? The fovea of the femoral head. You might also see it referred to as the fovea capitis. Capitis is referring to head. So the fovea, this is actually going to receive an artery, all right? There's an artery that goes into here. This is known as the artery to ligamentum teres. Why does it have that name? It's an artery that is embedded inside of a ligament. So imagine this, there's going to be a ligament that is produced from this fovea that comes out of it, and then inside of that ligament is going to be a small artery. Now let me put it into context for you so you could understand why that artery is there. So I'm going to fit the next part of this hip joint here into place so you can see. So the fovea of the femoral head is going to receive an artery that is coming from the acetabulum, specifically from where? So if we look at the acetabulum, like if we look at the hip bone like this, right? There's going to be inside of here in this pelvic cavity is going to be the pelvic cavity and a bunch of pelvic arteries that run out through the obturator foramen and then run into the acetabulum, okay? So here we're in the pelvis. Remember, there's another innominate bone on this side. The sacrum is right back here, right? The artery goes through the obturator foramen and then into the acetabulum like so. And then when it gets inside the acetabulum like so, then it's going to go into the femoral head, all right? So that artery is supplying blood to the femoral head. Now, why is this important? Let's talk about it. So the femoral head, all bones obviously need blood supply to stay alive. Now, what happens is that as you get older, this artery to ligamentum teres that supplies the femoral head starts to get stenosed, right? So it starts to get closed off and there's not as much blood flow that can get through it. And what ends up happening is that the arteries that come around the femoral neck, which are the medial and the lateral circumflex femoral arteries, those arteries basically take over as the blood supply to the femoral head, all right? So you start life off with having the blood supply coming from the artery to ligamentum teres. Then with time, as you get older, that artery closes off, and then the arteries from the femoral neck, the medial lateral circumflex femoral, take over that blood supply, okay? So why is that important? If you have a femoral neck fracture in a child, they still have the artery to ligamentum teres that is supplying their femoral head. Whereas in an older individual, let's say an old woman who is more susceptible to even getting a femoral fracture in the first place, an older person, if their femoral neck gets fractured, there is no artery coming from this direction to supply blood to it. The arteries that supply blood to this femoral head come from this femoral neck. So you can imagine that a femoral neck fracture could injure and compromise the blood flow that is coming from this femoral neck to the femoral head. So that is why in an elderly individual, a femoral neck fracture is a medical emergency. Whereas for someone who's younger, you can probably wait a day or two or maybe 3 before you get them into a surgical intervention. An older person, you want to get that fixed as soon as possible. Why? Because if this blood supply is compromised, then the femoral head could set into necrosis, and necrosis becomes a nidus of infection. A nidus of infection becomes septic, and sepsis can kill you. That's why, okay? So that's one point that I want to bring out there. So that is going to be one of the important parts of the femoral head and the femoral neck. So looking at this proximal end of the femur, one thing to note is the 2 large trochanters that we have right here. So this is going to be your much larger, greater trochanter, and this is going to be your much smaller, lesser trochanter, okay? Now, when the femoral head articulates with the acetabulum like so, the gluteal surface, which is this surface right here of the ilium, is where the gluteal muscles will be coming from. This is their origin. And then from here, they run down and attach onto this greater trochanter. So they're going to pull the greater trochanter to turn up this way towards the gluteal surface. So that's going to look like this, okay? That right there is known as abduction at the hip joint, okay? Or abduction of the femur. So that's how your gluteal muscles create abduction, is by pulling on that greater trochanter. Now, if we look on this anterior side, right, from the anterior view, I'm going to show you how the lesser trochanter works, okay? Now, the reason that I'm showing you this anterior view is because the lesser trochanter is going to receive the iliopsoas. So the iliopsoas is starting inside of the abdomen, right around in here, okay? And then it crosses right over this pubis like so, and is basically going to run on the anterior aspect of the hip to then go down and attach on that lesser trochanter right there. Okay, so basically when it pulls on that lesser trochanter, it's going to pull that lesser trochanter to come anteriorly like so. So notice that that is going to produce a flexion at the hip like so. Okay, that's how that works. Then when we look at the acetabulum itself, we're going to see that it's going to be composed of this acetabular rim over here. And then if you see over here, the acetabular rim is interrupted on the inferior margin. That's your acetabular notch. And then going through the acetabular notch, we then end up inside the acetabular fossa, where my finger is right now. The rest of this acetabulum is all the lunate surface, okay? So this depression in here is the acetabular fossa, but the rest of this whole acetabulum makes up the lunate surface, which is shaped like a moon, all right? The lunate surface is the surface that actually makes direct contact with the femoral head. And we can see how that works when we realize that this pelvic bone is resting on top of the femoral head like so, and all the weight of the body is going down. So it makes sense that the articular surface is on the superior part of this socket, okay? So that's where the major articulation is happening. And from there, the femur can go ahead and move all around. And right now, it is rolling and gliding on that lunate surface, okay? So here I want to give you an idea of what hip movements look like. So this is going to be one of the first joints that we look at in the lower extremity that has 3 degrees of freedom, which means it moves through 3 different planes, all right? So let's get the planes down first and foremost. And for that, I'm going to use this piece of paper to describe that. So the first plane I want us to look at is the sagittal plane. So the sagittal plane is going to run exactly how this piece of paper is oriented. The sagittal plane basically divides my body into a left and a right half. So it moves through this plane, okay? Any kind of movements that go through this plane are going to be producing flexion and extension movements, okay? So that's going to look like this at my hip, okay? This is flexion of my hip, or extension of my knee is this, okay? I'm just showing you a movement that goes through the sagittal plane. So from this view, it's like this, right? Any movement forward or backward is going through this sagittal plane. So right now, I'm producing flexion and extension at my hip joint. When I go forward, this is flexion at my hip, and this is extension of the hip. So flexion of the hip is going to be produced by any muscles that cross anterior to the hip, such as the iliopsoas. Anything that produces extension of the hip is going to run posterior to the hip. So the gluteal muscle is going to have some partial contribution to that, but mostly it's going to be coming from the hamstrings. So we're going to get that posterior movement like that, okay? Next plane that we're going to look at is going to be the coronal plane. So the coronal plane runs like this, okay? So I can put it next to my body like this. So the coronal plane is going to divide my body into an anterior half and a posterior half, okay? So movements that go along the coronal plane go side to side, right? They go with that plane. They go along that plane, right? So those are movements that go along this plane. So in talking about the hip, or if we're talking about the shoulder, these are movements that are abduction and adduction. So AB as in boy, and then AD as in dog, right? So abduction and adduction, okay, coming in. So for the hip joint, right, abduction, AB, is going away. I like to think about it as abducting the leg away from the rest of the body. And then adducting is adding the leg to the rest of the body, bringing it in closer. So this is adduction of the hip joint. Adduction of the hip joint is going to be done by the adductor muscles in the medial thigh. That makes sense. They're lying in the place where they need to be to pull this femur closer to the midline of the body. And the abductors are actually going to come from the glutes, right? The gluteal muscles are the ones that are going to cause the abduction by grabbing onto that greater trochanter, which is out here, and pulling the greater trochanter outwards. So let's take a look with the skeleton, what that would look like. So for example, this being my right innominate bone in my right femur, right? Abduction would look like this. Adduction would look like this. Flexion and extension. Now, let's take a look at the third plane, which would be the transverse plane. So the third plane of movement is a transverse plane. And the transverse plane is oriented like so, okay? So the transverse plane divides my body into a superior half and an inferior half. So movements around the transverse plane, let's think about what that would look like. That would be movements that basically go like this, right? And in the human body that's standing up and erect, what that looks like is rotatory movements, okay? So for example, if my head were here, right? If I was looking at the transverse motions of my head, that looks as like this, rotating side to side, because my head is moving through that transverse plane, okay? Or for my hip, what that's gonna look like is essentially my femur rotating in or my femur rotating out. So this is known as internal rotation and external rotation. You may also see it written as medial rotation and lateral rotation, okay? Anatomy textbooks or anatomy sources will most likely talk about medial and lateral rotation, whereas in the clinical sphere, we more so talk about internal rotation versus external rotation. Realize they're the same thing. So those are the main movements that are produced at the hip joint. So you can see that those are the 3 degrees of freedom. 3 degrees of freedom are what we see in ball and socket joints. So the glenohumeral joint, also known as the shoulder joint, is another ball and socket joint, which is also going to show us 3 degrees of freedom. And we'll see that once we get to the shoulder. So for now, I wanted to introduce you to that concept. I'd like to end this video with a discussion about hip joint stability, all right? So looking at this socket right here, that is part of the ball and socket joint, that is the hip, and looking at this ball, when we fit them into each other, we see that there's a fairly nice fit between them, okay? Compared to, for example, what we would see with the glenohumeral or the shoulder joint, right? Which is also a ball and socket joint, but look at that. Socket is much smaller than the ball in this situation, okay? Whereas for the hip joint, the socket is much larger and fits more of the ball into it. Now, what does this mean? For ball and socket joints, there's going to be a compromise between stability and mobility. The more stability you have, the less mobility you'll have. The less stability you have, the more mobility you have. And that is based on the relationship between the size of the socket versus the ball, okay? So in the hip joint, where we have a large socket comparable to the ball, we have more stability but less mobility. Whereas for the shoulder joint, a very large ball, much smaller socket, we have much more mobility, but less stability. So the shoulder joint gets dislocated much more often than the hip joint does. So in this video, we went over different bony landmarks on the femur, and we talked about the proximal femur in more detail. We talked about the articulation between the femur and the acetabulum, and we talked about the movements of the hip. If you like that video, hit the like button, hit the subscribe button. If there are future videos that you would like to see, please comment below and let me know what topic you want me to cover. If there's any questions that you have about this video, also feel free to comment below, or you can reach me directly at my email that you can see right here. All right? See you guys next time.